Default depression. How we now interpret distress as mental illness. This is printed in Mad in America. Science, Psychiatry, and Social Justice. It's written by Anthony Smith and printed February 1st, 2025. The spread of the medicalization of distress. The medicalization of distress has spread through the culture and bureaucracies of the mental health sector, organizational policy and practice in business and community sectors, and general medical practice. These sectors are integrally involved in the mental health domain and mutually contribute to maintaining the mental illness ideology. The role of the mental health sector. The core notion of the biomedical model imposed upon human difficulties and distress is that there's a biological basis to distress that can be diagnosed and treated, often with potentially harmful pharmaceuticals such as antidepressants. A focus on depression in Australia corresponded with similar campaigns in the US and in the UK and in the 1980s and 1990s. These international campaigns helped lead to the development of the National Depression Awareness Campaign, launched in 1994 by the Mental Health Foundation of Australia. This campaign was designed to educate the public that depression is serious, common, and treatable, and significantly influenced the initiation and development of Beyond Blue, still a leading player in the sector. The medicalized approach was given a boost with the equating of distress as an illness, prominent in mental health literature, accompanied by an encouragement to identify, diagnose, and treat the illness according to clinical guidelines such as the DSM and the ICD medical textbooks. Organizational policy and practice and mental health. The policies and practices of the biomedical approach to mental illness are not confined to the health and human services sectors. They now pervade our day-to-day lives. Governments at all levels sanction and promote the current approach through policy and substantial funding allocation and energetically partner with businesses and employers to make mental health a priority for organizations in all sectors. This unfortunate default response to distress now happens across the breadth of our community, all business and industry sectors, schools and higher education, the welfare and not-for-profit, entertainment and sport. Authorities such as human resources, personnel, and school counselors intervene and recommend or direct people, including school-aged children, to visit a doctor, GP, to determine or confirm a mental disorder. Following diagnosis, these patients are now treated with antidepressants, and all of this is now happening on a very large scale. The institutionalization of this default response to distress in the workplace has had an enormous impact on workplace health and safety. For example, mental disorders has surpassed musculoskeletal problems as a leading cause of long-term work incapacity in Australia for workers' compensation claims. Similar trends can be found on the international stage. As a consequence of this, there are escalating numbers of diagnoses for workplace mental disorders to the extent that mental health is now the main activity of general practice in Australia. Workplace mental health training. The medicalization of distress is promoted strongly through training, including workplace training, to identify a stressed person and presume them to be depressed, implying a clinically diagnosable depression. Whether or not the distressed person has a history of mental disorder and whether or not the stress is a result of difficulties completely outside of the individual's own making is largely irrelevant to this process. The training organizations that deliver workplace mental health training align themselves with and implicitly endorse the leadership of the current approach. Beyond Blue was a key pioneer of workplace mental health training in Australia and has been highly influential in the development of workplace mental health activity. In the 2004 Depression in the Workplace Program document, Beyond Blue describes aspects of its workplace training and a glaring example of pathologization equates depression with illness. Training enables participants to more clearly understand depression and conceptualize it as an illness, differentiating depression from normal sadness or stress. The role of general medical practice. GPs are at the pointy end of much of this unhelpful and often unnecessary medicalization process. For many decades, GPs, that's general practitioners, have played a key role in the challenges of dealing with work-related accidents and injury by providing diagnosis, advising, and facilitating the treatments required for return to work for workplace issues. GPs are therefore under enormous community, political, and business pressure to provide some form of mental health treatment to already large and still increasing numbers of attending patients with mental health issues. We now have a cultural expectation that GPs, as a part of their day-to-day practice, will routinely diagnose patients in distress for clinical depression and offer treatment that regularly includes prescribing antidepressant drugs. This culture is so pervasive and firmly established that many distressed patients presenting to GPs now actually expect this outcome, regardless of the factors involved in their distress. Bureaucracies across industries and other sectors, including education, further a formal diagnosis of mental disorder to provide follow-up support. And there is now a broad expectation that the GP will rubber stamp this process. Media and a mental health narrative. Media covering mental health has a strong preference for high-profile leaders of the mental health suicide prevention sector. These same figures also influence government and corporate policy, so that media coverage and policy development are heavily influenced by people who endorse the current approach, while contrary expert opinions are generally disregarded. Language. While we need change across a number of important aspects of our current approach to mental health and suicide prevention, if we're wanting change, our use of appropriate language is one key area that we can begin to change immediately. The use of appropriate language is vitally important in understanding people's distress and providing appropriate support for them. The terminology we use is fundamental to our understanding of the issues we face. The United Nations recognizes the inherent ambiguity in terminology in mental health and has commented on this. Terminology in the sphere of mental health is a contested terrain. There is a need to accept different terms according to how people define their own experiences of mental health. Mental health itself can signal a biomedical tradition of explaining and understanding lived experiences, psychic or emotional distress, trauma, voice, hearing, or disability. The special repertoire acknowledges this contested area and the importance of the health sector and of the medical model when used appropriately. He challenges stakeholders to reflect on how biomedical dominance has led to over-medicalization in the health sector, particularly in mental health. Developing a more effective approach to issues of mental health and suicide will depend upon the introduction of appropriate language and terminology and avoiding pathologizing language. Our understanding of key terms and definitions needs to be clear and consistent if our prevention efforts are to be effective. In default depression, I present a set of terms and definitions consistent with the best available current thinking and data. In some cases, these are new terms, while in other cases, they are commonly used terms with important clarifications added. There's been a good deal of interest shown from key organizations in the mental health suicide prevention sector in the themes of default depression and the language alternatives I propose. And there are several initiatives currently being developed using some of the content of the book in the core of new training modules for the suicide prevention mental health sector. Hopefully, we can soon provide a follow-up account of these initiatives so that they can be used as models for others to build upon, both in Australia and around the world.